Hello, welcome to the ESC TV Connect. My name is Borja Ibáñez. I am a cardiologist based in Madrid in the Spanish National Center for Cardiovascular Research and Hospital Universitario Fundación Jiménez Díaz. And I have the privilege of having two very important guests for the topic we're going to be discussing today, which relates to personalized medicine in the field of cardio-oncology. So I have the privilege of having Teresa López Fernández with us. As you know, she was the chairperson for the 2022 ESC Clinical Practice Guidelines on Cardio-oncology. And also we have Ricardo Ateggiano from Torino, Italy, who was the former chairperson for the Council for Cardio-oncology. Welcome, and thank you very much for being with us.
Thank you, Borja.
Thank you, Borja.
So as you know, the growing number of patients receiving anti-cancer therapies is increasing a lot in Europe, and thankfully many of these patients will survive. But as you know, there is a risk that they develop some form of cardiotoxic events. So the field of cardio-oncology, and specifically cardiotoxicity, is becoming a very important issue. However, it's very important to identify the patients who are at the high risk, so therefore it is needed to perform precision medicine to identify those who are at very high risk. So first of all, Teresa, I would like to ask you, in general terms, what is the approach from the clinical practice guidelines to this identification of patients at risk?
Thank you, Borja. This is a very interesting question because the first approach is to identify patients at high risk. That's exactly what the Resilience trial did, to identify patients who are at higher risk of developing problems when they receive anthracycline. Because we really need to concentrate our activity in these patients and to be sure that we optimize their cardiovascular conditions before cancer treatment and that we have good strategies to prevent cardiovascular problems. And ESC guidelines recommend to use the HFA-ICOS risk score, and we have recently validated this in the cardiotox registry, and it works really well to identify those patients who are at high risk of developing moderate or severe cardiovascular toxicity that are the big problem that can have these patients during or after anthracycline chemotherapy.
Very good. And within this ICOS risk score and other possibilities of identifying patients at risk, imaging is one of the most important or the most relevant tools. But can we afford imaging to every patient who will receive anthracycline? So how do you think should be done this?
Yeah, this is also very important because, as you know, most of our imaging resources are quite limited, but definitely, particularly for patients who have a high cardiovascular risk, to do a baseline imaging is needed to identify undiagnosed cardiovascular conditions that clearly increase the risk of developing a problem, and needs to organize a close follow-up based normally in echo, ideally in CMR when this tool is available and we can do short scan with all the information on a row to facilitate the implementation of CMR in our clinical practice. And the other important point to monitor patients is at the end of cancer treatment, because we really need to see what are the potential undiagnosed problems at the end of cancer treatment in order to organize the long-term surveillance.
So you mentioned CMR, cardiac magnetic resonance, which is a very nice tool because not only you can track anatomy and function, but also tissue composition, perfusion, and so on. So what would be needed to make a CMR widely available to a big proportion of patients that would like to have the MRI?
This is another very good challenging question. But I think that first, we need to be aware that, of course, not all patients that receive cancer therapies are going to develop severe cardiovascular problems. So if we identify patients who are at high risk, we reduce the number of patients that we need to scan. And then if we are able to perform cardiac magnetic resonance in a short time, and after a comprehensive baseline CMR, we really focus on what can change in a 3 or 4 months row, we can even shorter the time of a scan. So we make the technique more available for more patients.
This is because cancer patients, they are highly vulnerable. Some of them, they are elder. So ideally, you can make an imaging scan with a brief period of time, so they are inside the magnet for a few minutes.
Yeah.
It would eventually benefit a lot of patients.
The tolerance will be better. The adherence of the patients for follow-up will be also easier. And definitely, we will be able to save or to concentrate our resources on the right direction to be sure that we do not miss early signs of cardiovascular toxicity in this patient, because at that time is when we can treat the patients to minimize the risk of long-term heart failure or irreversible symptomatic heart failure.
And before we go to talk with Ricardo about the patients which are at the center of this process, the use of biomarkers is increasingly used also for early identification of cardiotoxicity, but there are some hurdles because eventually some tumors also they can be associated with increased levels of BNP and so on. So how do you see the future of the using of biomarkers for the early detection or even the high risk of each individual patient?
Yeah, biomarkers are definitely very interesting tool because are in general cheaper than cardiac imaging, and during the cancer treatment we extract a lot of time blood samples to the patients. But is it true that now we are just working with NT-proBNP or a cardiac troponin in daily practice? And as you mentioned, these biomarkers can increase not only because of cardiovascular reasons. So ideally, new biomarkers, new microRNA maybe that are involved in the mechanism of cardiovascular toxicity or that can assess mitochondrial function, and you have a lot of experience in this area. Maybe this is the dream, to have the perfect biomarkers that is really direct related with the cardiotoxicity and not with other cardiovascular or non-cardiovascular issues.
And let's say that we can perfectly identify, we know that the patient is at very high risk,
yep,
and we want to implement cardioprotective strategies. What is the state of the art here of the use of different cardioprotective drugs or interventions?
Yeah, we have limited information in that field now. So we have some good insights about the role of beta blockers, ESC inhibitors, statins to prevent anthracycline-related cardiotoxicity. But we do not have information with other cancer drugs. And the main problem is that not all patients tolerate beta blockers, or not all patients tolerate ACE inhibitors because they do not have a high blood pressure, or they have other problems that, or we have drug-drug interactions with cancer drugs. So ideally, to find a cardioprotective strategy that do not have drug-drug interactions, that could be awesome.
Thank you very much. So Ricardo, talking about novel interventions that could cardioprotect the heart in preventing cardiotoxicity, can you summarize what is the Resilience project, because what we bring us together today?
Well, I think that the novelty of the Resilience project is that this trial is trying to answer to many of the questions of the cardio-oncology field, that are prevention and treatment of toxicity. And in the Resilience project, we are analyzing the role of the remote ischemic preconditioning, the role of new biomarkers and of a new MRI sequence, trying to answer to what taught before Teresa about the assessment of the patient with a short protocol that should answer to all the problems of long-term MRI analysis. But one of the most innovative aspects of the Resilience project is the deep involvement of patients. Essentially in two ways. We are evaluating with PROMs and PREMs the results of the intervention of the trial, and we are trying to enhance the patient empowerment that is essential for a good development of their condition, education, information, and so on, essential for the long-term care of this kind of patient.
Very nice. So one of the main activities of Resilience was to hear the voice of the patient, as you have mentioned.
Yeah.
Because in classical cardiology, we're used to use classical heart outcomes, mortality, heart failure admission, but maybe for patients there are other things that matter.
Yeah.
So how is resilience getting the information from patients?
Yeah, there is a very complex project about the patient to collect their information. The Resilience has adopted an app, a special app that allow direct contact patient researchers to collect the PREMs and PROMs
In real time.
in real time. So this allows to have a very good exchange of information. This requires the help of nurses, the use of specific material, the project of a specific website, and the use of social media to exchange all this information. And moreover, in the Resilience project have been produced some local encounters, putting together the researchers and the patients enrolled in the trial. And also we had one, and we will have another international meeting at the European Art House where all the stakeholders taking part with the project are exchanging and exchanged their experiences and in comparison of all their aspects of the trial, to have an exchange of ideas and of feelings about this very important problem of cardiac toxicity.
Yes, certainly this was one of the highlights of Resilience, this multi-stakeholder meeting, one at the beginning and one at the end.
Yeah.
Just for the audience, just to remind that Resilience will enroll 600 patients at risk for cardiotoxicity and randomize them to remote ischemic conditioning during the entire duration of chemotherapy or some procedure. And the primary outcome is CMR measure systolic function, but also there will be many other measures. So just before we finish, let's say that Resilience demonstrates that remote conditioning preserves cardiac function in this kind of patients. Will this make the clinical practice guidelines?
Well, this is a randomized clinical trial. It's what we need in cardio-oncology. So, of course, as you know, the inclusion of new recommendation in ESC guidelines is a long process and needs a multidisciplinary team to agree and to review the literature, but definitely this type of data are those we need to improve the quality of our recommendations and to improve the evidence on how to protect the heart of our patients. So
okay.
We are
Fingers
more than welcome.
Okay, thank you very much. Just as a quick wrap up, so we have been discussing the Resilience project, which is a European Commission funded project in which the European Staff of Cardiology actively participates, and Teresa and Ricardo, they are the principal investigators from the ESC. And hopefully this study will inform not only about any potential preventive therapy, but also novel diagnostic markers, and more importantly, as Ricardo has highlighted, the participation of patients. So stay tuned for the results of the Resilience. We will come in a couple of years from now, maybe, hopefully. And in the meantime, we encourage you to visit all the different web pages and the social media for Resilience. Teresa, Ricardo, thank you very much for joining us.
Thank you, Borja.
Thank you, Borja, for all your work.
Thank you. Have a great meeting.
Thank you.